Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing in detail about ovarian cancer. So we'll be discussing various types of ovarian cancer, that is epithelial ovarian cancer, germ cell tumor, stromal cell tumor and borderline ovarian cell tumor. We will be also discussing in detail about the staging and the stage-wise management as well as the prognosis, the stage-wise prognosis. So stay tuned, you should find it helpful. Ovarian cancer, it is divided into epithelial, germ cell, sex cord-stromal tumor. So CA125, this is the recommendations for doing it. It is advised for all women with red flag signs raising the suspicion of ovarian cancer, especially if they're more than 50 years. Okay. And the symptoms include bloating, early satiety with a reduction in appetite, pelvic or abdominal pain, increased urinary urgency and frequency. Other symptoms include unexplained weight loss, unexplained fatigue, unexplained change in bowel habit, new symptoms of irritable bowel syndrome in females who are more than 50 years.
Okay.
Then for patients with symptoms of ovarian cancer, the current national guidance recommends CA125 as an initial investigation. And if it is more than 35, then you have to do an ultrasound, abdominal and pelvic. And it has high specificity for identifying ovarian and primary peritoneal cancer. However, for follow-up, there is questionable role. So CA125 during follow-up is not mandatory and has not proven to be of survival benefit, as 40% of the patients achieving normal CA125 with microscopic and macroscopic disease will be found at second look surgery. However, the decision for CA125 follow-up must be individualized.
And what is the cutoff?
35.
35.
Then what are the risk factors? So OCP, basically it reduces the risk of ovarian cancer. So if a person is using OCP for more than 20, there is more than 20% risk reduction if the patient has been using OCP for 5 years.
Okay, ovarian and ovarian cancer.
Yeah, and more than 50% risk reduction if she has been using it for 15 years. Okay, so it is OCP is protective. Tubal ligation also is protective because it has been seen that ovarian cancer, it originates from the tubal end of the tube, like fimbrial end of the tube.
Okay.
That's why tubal ligation, salpingectomy, all this is protective.
Okay.
And protection provided is around 34%. And in case there is ovarian endometriosis, what is the chances of undergoing malignancy? Then it is 2.5%.
Okay.
Overall, most common cancer in female is breast, followed by lung, bowel, womb, and melanoma. In UK, the most common cancer is breast. And if they ask you most common gynecological cancer in female, then it is uterus. And most common gynecological cancer causing death, then it is ovarian. Okay.
So most common cancer is breast.
Yeah.
Most common gynecological cancer is uterus. If they ask specifically gynecological cancer.
Yeah.
And which is causing death is ovarian cancer. Okay.
Then how do you stage? So stage 1 here also is limited to ovary. Okay. 1A is one ovary, 1B is both ovaries. 1C is if there is surgical spill, like you are operating and the cancer opens up and there is spill. 1C2 is capsule spontaneously ruptures on its own and tumor cells are present on the ovarian surface. And 1C3 is if ascitic fluid or peritoneal cytology comes out to be positive. Okay.
Surgical spill. Okay. During
Surgery, you are operating, you're doing surgical staging, you're operating the ovary and the tumor bursts.
Okay. Okay. So okay, iatrogenic. Okay.
Okay. Then stage 2 is always local spread. So from the ovary it will spread to uterus or fallopian tube, that is 2A, and other pelvic structures it is 2B. Okay.
Okay. What is positive washing?
Washings is ascitic fluid you take, no? You send it for malignant cytology, it comes out to be positive. Or you take, while you are operating, you put some saline and you send it for testing, and it comes out to be positive.
Okay.
Okay.
So they are saying, okay, it means that malignant cells in acidic fluid are positive.
Yeah. That is 3C, 1C3.
Okay.
Okay. Then 3 is nodes involvement. Okay. 3A is positive retroperitoneal lymph nodes. A1 is less than 10 mm. A2 is more than 10 mm. Then 3A2 is microscopic extra pelvic peritoneal involvement, with or without, if there is extra pelvic peritoneal involvement, so momentum comes out to be positive, that is 3A2.
Okay.
Okay. 3B is macroscopic. 3A2 is microscopic peritoneal involvement. Here it is macroscopic extrapelvic peritoneum involvement.
So 3 is node involvement.
Hmm.
Less than 10 is 3A1, more than 10 is 3A2, and under 3A2.
This 3A2 is different, no?
Oh,
They have put it
okay,
like
that is
this.
3A only. Okay. Here comes 3A2. So 3A1 is involvement of node. 3A2 is peritoneal involvement.
3A2 is microscopic
Microscopic.
extrapelvic peritoneal.
Okay.
Macroscopic
3B is
less than 2
macroscopic.
centimeter. Macroscopic less than 2 equal to 2 centimeter is 3B. Macroscopic more than 2 centimeter is 3C.
3C.
And even extension to capsule of liver or spleen is
Okay.
also 3C
Okay.
without parenchymal. Only capsular involvement of liver and spleen is 3C.
Okay.
Okay. And if parenchyma is involved, then it is 4B.
Okay. Okay.
4A is pleural effusion, positive for cytology, and 4B is distant mets where like liver, spleen, parenchyma involvement, brain,
Okay.
bones involvement, everything. Okay. So this is the ovarian cancer staging. Then how do you diagnose? You diagnose by doing a surgical staging. So I told you for endometrium and this ovarian, it is surgical staging. Okay. And plus it can be complemented by imaging like CT scan, tumor markers like CA125, and biopsy. Biopsy is that surgical staging which you send for histopathology. Okay.
Okay.
And in what all cases can you do fertility sparing surgery? If it is stage 1A
Mm.
differentiated, that is grade 1 and grade 2.
Mm.
Okay.
Mm.
And stage 1, 1A grade C also you can think of doing. Stage 1C grade
Mm.
1 also you can think of doing. And what is the fertility sparing surgery that you do? You remove the same side tube and the ovary, you
Mm.
remove the omentum, you do peritoneal sampling of paracoidic and subdiaphragmatic regions, and lymph node assessment. If they are enlarged, you remove them.
Okay.
So this is fertility. You do not remove the uterus and contralateral tubing
Okay. Mm.
when ovary. Other things you do the same. Okay.
Anyhow, they'll be under follow. Mm.
Yeah. Then this is the stage wise management. Stage 1A, 1B,
Mm.
grade 1, grade 2. You can just do surgical staging. No need for chemotherapy.
Okay.
1A, 1B, grade 3
Mm.
or 1C, all grades. You do surgical staging and now you have to give chemotherapy. You give 3 to 6 cycles of carboplatin.
How like this is stage 1A to 1B. Oh, grade 1 and grade 2. Okay.
Yeah, grade 1 and grade 2.
Like for endometrial cancer.
This is ovarian we are studying.
So even in endometrial carcinoma for grade 1 and grade 2, there is no.
Even for endometrium, it was no.
Okay.
There we were doing primarily radiotherapy. No, here it is chemotherapy.
Okay.
Endometrium not very sensitive to chemotherapy. So, but ovarian is quite sensitive.
Okay.
Okay. So stage 1A, 1B, grade 3 and 1C, any any grade you do surgical staging followed by 3 to 6 cycles of chemotherapy. You give carboplatin.
Okay.
Stage 2, 3A and 3B. You do
Mm.
surgical staging, chemotherapy with the carboplatin and paclitaxel, and here you give 6 cycles.
Okay.
Okay,
Mm.
3C and 4, these are advanced cancer. So here first you give neoadjuvant chemotherapy. Like first you start with chemotherapy,
Mm.
the tumor size reduces, then you do the surgery, then you give another 3 cycles of post-op chemotherapy.
Neoadjuvant 3 cycles followed by surgery, followed by rest 3 cycles of chemo. Okay. Mm.
And 4B is palliative therapy.
Mm.
Okay.
Mm. Okay.
Then docetaxel is an option in patients who have significant allergic reaction to paclitaxel or who develops early sensory neuropathy, as it has less neurotoxicity but it is more myelosuppressive than paclitaxel.
Mm.
Okay.
Okay.
So if anybody has allergic reaction or develop neuropathy, so instead of paclitaxel, you give docetaxel.
Okay.
And if carboplatin
Okay. Mm.
hypersensitivity
Okay.
is there,
Mm.
carboplatin, then you first try to desensitize them, or you can give cisplatin.
So if allergic to carboplatin, cisplatin.
Yeah, or you try desensitization. Clear? Then this is again about the survival for ovarian. 1 year survival is 72%.
Okay.
5 year survival, as you can see, it is the lowest amongst all four. Okay,
PST
so
is
it is only 43% overall. Okay. Then about germ cell tumor, 15 to 20% of all ovarian tumors are germ cell. These generally occur in young women in their early 20s and mostly they are unilateral. And most common germ cell tumor is dysgerminoma seen in 48% and it is bilateral in 10 to 15% of the cases.
Okay. Mm.
Okay, so germ cells can be differentiated or undifferentiated.
Mm.
Undifferentiated is dysgerminoma.
Mm.
Okay, differentiated if they arise from whole blastocyst, then
Mm.
it is embryonal carcinoma. If they
Mm.
arise from embryo, then it could be teratoma, mature or immature. They
Mm.
arise from yolk sac, it is yolk sac tumor. They arise from trophoblast, they are called choriocarcinoma.
Okay.
And tumor markers for these are important. For dysgerminoma, it is LDH and placental alkaline phosphatase, PLAB. HCG may or may not be positive in these cases. Yolk sac tumor, alpha fetoprotein, and choriocarcinoma, it is HCG. Okay.
Okay.
Teratoma, there is no marker which can be positive. Okay. Then how do you diagnose these patients? Again, by same surgical staging,
Mm.
imaging, tumor markers, and biopsy.
Mm.
Okay.
Okay.
Then how do you manage? For germ cell tumor, you can do conservative surgery because these are generally in young patients.
Mm.
You cannot remove everything, uterus, ovaries, both. You cannot do that. And plus, they are not very much aggressive. So you
Okay. So only the affected ovary.
yeah. So you do limited cytoreduction. What you leave the uterus and contralateral ovary. You just remove the ipsilateral ovary.
Okay.
You do unilateral salpingo-oophorectomy for these cases along with omentectomy.
Mm.
Okay.
Okay.
And have completed, if the patient has completed family, then you remove the uterus and both ovaries.
Okay.
But you need not remove the lymph nodes, you need not remove the adjacent uh, peritoneum and all like do
Biopsy of
anything.
a normal ovary not required.
That is, you just remove the
Only
affected.
the affected ovary. Okay. Other one is left
You
as
need
is.
not even send for biopsy the other
Okay.
ovary.
Mm. Okay.
Then how do you manage dysgerminoma if it is early stage?
Mm.
Then 1A, 1B, you just do the surgery and surveillance. 1C, you have to give chemotherapy.
Mm.
Chemotherapy, you give BEP, bleomycin, etoposide, and cisplatin combination. Okay.
Okay.
For
Three cycles
non-dysgerminoma,
of what is it now? 3 cycles of B.
bleomycin, etoposide, and cisplatin.
Okay. Mm.
And non-dysgerminoma, you do surgery and post for early stage, same like this 1A, 1B, grade or 1C, grade 1 and 2, you just do surgery and post-op surveillance. For
Mm.
grade 3, 1C, you can either do surveillance or post-op adjuvant chemotherapy. And if stage 2 or greater in any of these cases, you have to give neoadjuvant chemotherapy followed by surgery followed by chemotherapy. Okay.
Mm.
So
What is this BEP?
bleomycin, etoposide, and cisplatin, combination of three medications.
Okay. Mm.
Okay. So optimal duration of therapy is debatable, but 3 cycles of BP with completely resected disease and 4 cycles for patients with macroscopic residual disease seem to be appropriate.
Mm.
And patients who relapse after BEP, you can give second line chemotherapy, which is paclitaxel, ifosfamide, and cisplatin.
Okay. Mm.
Okay. The women who should be counseled to avoid pregnancy for the first 2 years following the treatment.
Okay.
Again, this is important, can be asked.
Mm.
So, following chemotherapy, they have to avoid pregnancy for 2 years. And
Mm.
how do you follow the stage 1 cancers? You
Mm.
have to do like baseline CT, chest, abdomen, pelvis if it was not done on before, and you have to do it 3 months after the surgery. Then
Mm.
you have to again repeat it at 12 months. And pelvic ultrasound, you have to do it at alternative visits for 2 years.
Mm.
And if non-dysgerminoma, for dysgerminoma, you do it for 3 years. And chest X-ray at alternative visits. And how frequently do you call the patient? For the first year, clinical examination every monthly.
Mm.
For
Okay.
second year, 2 monthly. Third year, 3 monthly.
Mm.
Fourth year, 4 monthly, and 5 to 10 years, 6 monthly. So till 10 years, you have to follow up. And tumor markers, how frequently you do for
And
the
what do we do during the follow-up period?
all this CT, MRI,
All these investigations. Okay.
and also tumor markers. And tumor markers, how frequently do you do? For first 6 months, you do it 2 weekly. For up to 1 year, you do it 4 weekly.
Mm.
1 to 2 years, 8 weekly. 2 to 3 years, 12 weekly. 36 to 48 a month, 16 weekly. I don't think this will be asked in so much detail.
Okay. Mm. Even if they are negative, these many follow-ups are
Follow
required.
up has to be done to look for relapse.
Okay.
Okay. Then sex cord-stromal tumors. These are mostly seen in adults.
Mm.
These are mostly functional, producing clinical manifestations.
Mm.
Then two types of sex cord-stromal tumors are there. One is granulosa cell. The other one is Sertoli cells.
Mm.
Of these, granulosa cell account for 3 to 5%, and 70% of sex cord stromal tumor. So overall, if you see overall from the ovarian tumors, it is just 3 to 5%, but it
Mm.
is the most common type of sex cord stromal tumor, accounting for 70%.
So granulosa cell tumor alone accounts for 3 to 5%.
Hmm.
70% of all how.
See, ovarian cancer can be germ cell, epithelial, sex cord stromal.
Mm-mm.
Okay. So among
Okay.
the sex cord stromal tumor, there are two types of sex cord stromal tumors.
Mm.
70% is granulosa, 30% is Sertoli cell.
Okay.
Overall, there are so many cancers. From that, granulosa cell is 3 to 5%.
No. Granulosa is 70% and Sertoli is 30%.
Yeah, from the sex cord-stromal tumors.
Okay. Then how come this granulosa cell tumor is accounting for only 3 to 5%? Very less.
All ovarian tumors. So most common ovarian tumor
Okay,
is
like all ovarian tumor. Hmm?
yeah.
Granulosa is 3 to 5. Then which is 70%?
Of all ovarian tumors, granulosa cell is 3 to
Yeah,
5%.
I got it, ma'am. Like all ovarian tumor, it accounts for 3 to 5%. When it comes to sex cord, it is 70% and Sertoli is 30.
Yes.
Okay.
Okay. Sertoli cell, there is increased androgen, so it causes virilization. Granulosa cell, it releases estrogen, so it causes precocious puberty or postmenopausal bleeding.
Okay.
And markers for granulosa cell tumor is estrogen, inhibin B, and AMH. Okay. And staging is same as epithelial ovarian cancer.
Okay.
Then how do you manage? If it is early stage, that is 1 to 2A, you do surgery, that is surgical staging. Any post-op chemotherapy is still controversial, although 1C and 2A some people give. 2B4, you have to do debulking surgery, and you give here you give chemotherapy, same like germ cell BEP. Okay.
Debulk. What is debulking surgery?
Debulking is as much as possible you try to remove, because complete it is advanced stage. No, complete removal will not
Other
be
than
possible.
ovary, what do we remove?
Whatever is involved.
Okay.
So if
Okay.
vagina is involved, you remove the vagina,
Okay.
parametrium. So whatever lymph nodes, so
Okay.
whatever is involved, you remove
Okay.
as far as possible.
Okay.
Okay. Then fallopian tube is as a origin of non-uterine pelvic high-grade serous carcinoma. So it has been seen that femoral end of the fallopian tube may more commonly be the source of origin of non-uterine high-grade pelvic serous cell carcinoma of tubal ovarian or peritoneal sites than previously thought, even in BRCA positive females. So usually it has been seen that these cancers, they arise from the femoral end of the fallopian tube,
Okay.
ovarian cancers. And there are studies which have shown that if patients undergo risk reducing salpingo-oophorectomy, so sometimes there are occult tubal cancers or intraepithelial cancers in the tubal fimria.
Okay.
So for risk reducing salpingo-oophorectomy, the entire fallopian tube should be submitted for evaluation with special attention to the femoral end.
Okay.
So, for the current preventive strategies for ovarian cancer, one is OCP because it stops the ovulation, and second is salpingectomy. It reduces the risk of ovarian cancer.
Like this, they are saying as prophylactic measure.
Yeah.
But how can we give OCP?
So the OCP is protective, no? You
It is protective for ovarian, but there is risk of endometrial and breast cancer.
no if they're just saying that endometrium also it is protective. Breast cancer and cervical
Breast and
cancer.
cervical. Breast and cervical.
Yeah. So for the patient who is taking OCPs, they're just saying that it is protective.
Okay.
Okay. Even for removal of the tubes also, they're just saying it is protective. Not saying that you give OCP to everybody or you remove the tubes of everybody.
Okay.
They have just said that it is protective, but in patients who have high risk of ovarian cancer, like even BRCA positive, where after completing family, you are going for prophylactic removal of the ovaries. So you also remove the tubes. That's what they are trying to say.
Okay.
They're not planning for pregnancy, you can give them OCP because it is protective.
Okay. Okay.
Then borderline ovarian tumors. So, what is the difference between the ovarian cancer and borderline ovarian tumor? There is no stromal invasion. There is no protection for OCP. There is no relation with BRCA. Okay, for borderline ovarian tumor, lactation is protective for both. Okay.
Okay. Mm.
Ovarian cancer usually associated with P53 mutation, whereas borderline ovarian tumor associated with BRAF and KRAS mutation.
Mm.
Survival rates are much better for borderline ovarian tumor.
Mm.
Okay. Where 10-year survival is 35%, for
Mm.
ovarian cancer it is 70 to 80%.
Okay.
Okay.
So these borderline tumors also cancerous only.
No, they're borderline.
Mm. Okay.
They're not cancerous, but
But survival
borderline.
rate, okay. Mm.
They're not normal
Higher.
also.
Mm.
Okay. So
So like OCPs protect only ovarian cancer, not the borderline tumors.
yes.
Okay.
Okay. So if borderline ovarian tumor is detected, you refer them to cancer center.
Mm.
Then you check whether they desire fertility or no. If they
Mm.
do not desire fertility, then you do the complete surgery and close follow-up. Complete surgery
Okay.
means you remove the uterus, you remove the tubes, you remove the
Okay.
omentum,
Okay.
and you
Mm.
follow. If they desire fertility, then you see whether it is early stage or advanced stage.
Mm.
Stage is also same like ovarian cancer. Okay.
Mm.
If it is early stage, you can do conservative surgery. If it
Okay.
is advanced stage, then you cannot do like if there are non-invasive implants, then
Mm.
you can do conservative surgery till the family is complete and close follow-up. In advanced stage with invasive implants, you have to do complete surgery.
What are those implants?
So these are implants on peritoneum or other surfaces. You see whether they are invading or they are also borderline.
Implants means those
Metastatic,
cancerous
just told
metastasis. Okay,
you.
metastasis. And what do they do in conservative surgery?
Conservative, they just remove that ovarian tube. Epithelial ovarian tube.
Okay, only the part which is affected.
Yeah.
Okay.
Okay. So for management, MDT has to be involved.
Mm.
You have to do surgery is same as epithelial ovarian cancer if the family is complete.
Mm.
Staging, which involves staging and cytoreductive surgery with lymph node removal. Approximately one-third of the cases reported as borderline at frozen section are later classified as invasive tumors.
Okay, and so in all cases, momentum is removed.
Yeah, omentum you remove in all. So what do you do? What all do you remove? You do agar if you are doing conservative surgery, what does that mean? Cystectomy,
Okay.
unilateral salpingoophorectomy,
Mm.
with or without infracolic omentectomy, peritoneal washing, and complete examination.
Okay.
And
Mm.
about 20% of these cases, the tumors come back in
Mm.
the ovary that is left. So there is high chances of recurrence. So that's
Okay.
why you
Mm.
have to follow them very frequently. You follow them up every 3 monthly for the first 2 years,
Mm.
every 6 monthly for the next 2 years, and annually thereafter.
Okay, they are removing the ovary itself. Then why they are mentioning cystectomy?
See, either they do some cystectomy nowadays, nobody is doing, they're removing mostly the ovary only.
Mm.
So, suppose if there is a cyst in the contralateral ovary, then probably cystectomy in the contralateral ovary.
Okay. Okay, ma'am.
Otherwise, if only one ovary, they remove the entire thing.
Okay.
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 Then, following primary surgery, so you have done the surgery for borderline ovarian tumor.
Mm.
Okay. But if you find if there are invasive implants, or if
Okay.
there is DNA aneuploidy, or if there is micropapillary tumor, then you
Mm.
have to refer the patient for regional cancer center and you have to do restaging and complete surgery now.
Okay. So following the surgery, when these are present in the, how come like we are removing the entire ovary and tube? So in the contralateral side or where?
No, no, you are removing the tube ovary also omentum you are removing, no?
Okay. Then
If
where do we find these invasive implants? Post
can
surgery.
find on the surface because you're sending the tissue, no, for analysis. So if anywhere either you find the invasive implants or if you find that the DNA nucleus there is aneuploidy
No, no,
or
this they are making out of the excised tissue.
yes,
Okay. Okay.
okay, then you
Mm.
have to do the complete surgery. You have to do restaging.
Okay. Mm.
Okay, and restaging will include, you'll again do a second surgery where you'll do peritoneal washings, omentectomy, complete examination of the peritoneum, and removal of the contralateral ovary also.
Okay, in resurgery, like what do they do?
All this, I
No, already they removed everything.
no, one ovary was left. No, now they're
Oh,
removing the
okay, we are
other.
examining the normal side.
Yeah,
Okay.
and you're removing the other things also. If there is omentum is not removed, you remove
Okay,
omentum
okay. If
also.
anything left out on the ipsilateral side, we are removing those. Okay.
Yeah. Restaging does not appear to differ in the survival and recurrence rate. It it depends, basically what you are doing depends on the histological subtype, completeness of the primary surgery, and what are the fertility desires of the patient.
Doesn't appear to differ. Okay, and here they are removing the contralateral ovary. If
Yeah,
the,
but
okay.
yeah, so that's what I told. No, if
What
in
if
laser
it was
implants you
why?
usually have to remove.
No, like what if it was good? Why they are removing unnecessarily?
What if?
What if it was good?
No, no. These are, if these things are present, no, then
Present in the removed ovary.
then there are high chances of metastasis.
Okay,
So
okay.
that's why you have to remove.
Okay, to be on the safer side.
Yeah. Then, if a borderline ovarian tumor, there is no role of chemotherapy. You give chemotherapy only when it is unresectable.
Okay.
And there is no role of laparoscopy also, because it has been seen in, that the recurrence rate of borderline ovarian tumors are quite high. It
Okay.
ranges from 0 to 58%, and recurrences are usually easily resectable.
Okay.
And after why do they do this radical surgery? Because recurrence rate is more with cystectomy. It is 12 to 58%. Salpingoophorectomy, it is 0 to 20%. And with radical surgery, where they're doing the peritoneal washings, moving the omentum, all that, removing the tube, then it is 2.5 to 5.7. So recurrence are less if they're doing radical surgery.
Okay.
So this
But
was all.
how do they do cystectomy when it is cancerous? Supposed to remove the entire ovary. Then why they are going for
Then
cystectomy?
you should not do cystectomy. If the patient is adamant that she wants
Okay.
to complete the
Okay.
family, she doesn't want to go for it, you don't have a chance. But you have to
Okay.
counsel that there are very high chances of recurrence.
Okay. Okay. Okay.
Okay, so this was all.
So this was all about ovarian cancer. I hope it was useful. Thank you so much for watching.